Welcome to another edition of the Invisible Wheelchair Interview Podcast. I'm Donald Grodoff, family coach with FamilyOCD.com, FocusedHealthyFamily.com, and of course, InvisibleWheelchair.com. In the Invisible Wheelchair interviews, I get the wonderful chance to interview some of the experts with obsessive compulsive disorders, professionals that treat OCD, people who are going through or have been through OCD, parents and caregivers of those suffering from OCD, and of course anyone that advocates for treatment of OCD. My goal of these interviews is to inform people on all aspects of OCD and bring about awareness of obsessive compulsive disorder. Please remember that I am not a doctor, therapist, or counselor, and the content, information, resources, and ideas that are talked about and brought up here in these interviews are not necessarily the views and opinions of myself, Family OCD, Focused Healthy Family, and Invisible Wheelchair Podcast, and I always recommend to seek additional professional help in finding solutions for yourself. You can find out more about me at FamilyOCD.com, FocusedHealthyFamily.com, and InvisibleWheelchair.com. This podcast interview was recorded March 14, 2018. Today I have the great honor and privilege of introducing you to Dr. Joseph Parisi. Dr. Parisi received a bachelor's degree with honors in psychology from the University of Connecticut. He completed an M.A. in clinical psychology at the University of Hartford and was awarded a Ph.D. in clinical psychology from the California School of Professional Psychology. Dr. Parisi was the Director of Psychology and Behavioral Medicine at Presbyterian Hospital for 14 years. During that time, he established the hospital's Center for Mind, Body, Health, and co-founded the Center for Integrative Medicine. Prior to that, he was the Director of Psychology at Charter Pines Hospital, where he developed and directed the hospital's Anxiety Disorders program. Dr. Parisi established and has maintained a private practice in Charlotte, North Carolina since 1979. He is in practice with Charlotte Behavioral Health Associates and is the president of the Mecklenburg Psychological Association. With that said, let's go to the interview now. Well, Dr. Parisi, thank you so much for being part of the Invisible Wheelchair Podcast. I know my audience is going to be really interested in what you have to say because you work in this therapy of helping people through OCD. So thank you for being part of this.
Well, thank you for having me. I'm happy to be with you, and in any ways that I can be helpful today. I hope it'll turn out that way for folks.
What I ask my participants in this is to give the audience a little bit of information about yourself, maybe a story about how you got started, some personal information about you, so they can kind of get to know you and understand the type of practitioner you are, the type of person you are. So if you could share some with us, I would really appreciate that.
I'd be happy to, Don. My training is as a psychologist. I originally went into psychology making that decision in college when I realized that it was helping people, communicating with people, understanding people, and being able to help them that provided me with meaning in life. That realization took me down the path so that I was trained and eventually got my degree in clinical psychology. I developed a particular interest in the anxiety disorders, of which, of course, OCD is an anxiety disorder. Number one, because I tend to be anxious at times, and I'd see something and I'd say, oh, I could probably use that too. And a lot of the interventions I would try out on myself. And OCD especially came to my radar screen because I found, and this was later on, but I found that as I got stressed, I would begin developing some OCD symptoms myself in the area of scrupulosity. That gave me a gut level sense, of course, of, boy, this is horrible. And I'm happy to say I used exposure and response prevention for myself, and it worked. But it gave me even a keener interest in helping people with OCD.
So are there questions that you answer, just seems like over and over again, about helping people in your help with people?
Well, when people come to see me, they typically are confused and anxious and oftentimes frightened and ashamed by what they're thinking. One of the first questions they have, or they may be wondering, they may not say out loud, is, am I crazy? I'm having these thoughts, I'm having these desires, and they don't make sense to me. Does this mean I'm crazy? The answer to that question is no, not at all. That if you believed all the thoughts you were having, then yes, we'd have another problem. But it's precisely because a part of our brain with OCD can stand back and say, what I'm doing now is ridiculous. It's not making sense to me, but I'm feeling such a strong need to do it. That's the definition of OCD. It's not rational, but it has absolutely nothing to do with being crazy, nor can you go crazy from OCD. So sometimes with some of my clients who look at me a little askance with that, I'll say, I'll tell you what, I'll write you a check for $500, and all you have to do is come back next week and be crazy. And the check is yours. In 30 years, I've never had anyone win that bet.
Okay.
It's always a safe bet to make. The second fear people sometimes have is that maybe they've been exposed to some treatment or they've seen something on television where they've seen someone, let's say they have a fear of germs, and of course on TV they always go for maximum effect for the audience. And so they have somebody, inside a garbage can licking it, or, just some outrageous behaviors. And they'll say, am I going to have to do stuff like that? And the answer is no. Everything that we do, you're going to be in control of. We're going to decide together whether it's a good idea or a bad idea to do it and what the rationale behind it would be. No, the things you see on TV aren't necessarily the way we're going to proceed. No, you're not going crazy. And then the third question is just a general one, which is, well, what is wrong with me? What is this thing called OCD? There are a number of ways to answer that, but foremost is that it would not surprise me, and it's hard to give a time span of, let's say, maybe 30 years, 40 years from now, I'm not sure it will still even be listed as a psychological or psychiatric disorder, and instead might be listed as a neurological disorder. Clearly, we have enough evidence now and understanding using PET scans and other interventions so that we know which parts of the brain are involved with OCD. We can begin to look at the neural pathways and how the brain is essentially short-circuiting itself around a particular group of thoughts. That's a neurological problem then that has psychological ramifications and symptoms. That's one of the first things I tell folks also when they see me, Don, which is, this is not your fault. It has nothing to do with not having enough willpower. It has nothing to do with not trying hard enough. This is a neurological disorder that is very insidious because the very things that we would instinctively want to do to make it better makes it worse. And the very things that will make it better are things that the OCD will tell us not to do. Instinctually, it leads us down the wrong path, but because we tend to follow our instincts, of course, by the time people come to see me, they've been making it worse, oftentimes for many years, as they've tried to help themselves.
I would like to hear your perspective, and if you work with or do anything with pandas or PANS.
My practice is limited largely to adults, some older teenagers, since pandas is more seen in children. I don't see a lot of it. Occasionally I'll get a phone call from someone on the telephone about their child, and as they're telling me the situation, it'll sound an awful lot to me like pandas might be a possibility, and I'll suggest that they seek out a pediatrician or someone who's knowledgeable in that area. As an adult psychologist, I don't see a lot of that, so no.
So in other words, by the time they're into their teens or adults, they would have, even if it was pandas that started it, it would be really kind of too late as far as using, because a lot, what I understand in pandas and pans is that if caught in time, what do you call it? They can get a shot, they can get a shot that can help in some ways. But by the time you would see them as an adult, even if they started out as pandas, it would be beyond that, and now it would be just into like the ERPs and that kind of therapy. Would you say that's correct?
Yes, that's correct. I have not seen any literature, and perhaps it's out there and I just haven't seen it yet, of adult onset pandas or PANS. And we don't know why that is. I haven't seen any literature either about children who are diagnosed with that and then become adults and how that plays itself out. That would be interesting to see. And I haven't had any, and I've seen lots of folks with OCD, but I haven't seen anyone that I can recall that would meet that criteria.
What I was going to ask you is if you could tell us a little bit about how you do treat, what your treatment method or style is, and how you use it.
As I said a moment ago, the treatment is counterintuitive. I use what we call exposure and response prevention, but break it down into different parts. So for someone, let's say, who has a fear that their hands might be contaminated by germs, and of course they're coming to see me, and here they are coming to an office full of healthcare professionals, and they may walk in the waiting room, and sure enough, that'll trigger the OCD. If they did not have OCD, and they were worried that, geez, maybe I've just contaminated my hands, it would make all the sense in the world to go wash them, and that would solve the problem. But that's if you don't have OCD. If you do have OCD and you get that message, it's important to understand, now let me take a sidestep here too. What's happening is that the emotional part of our brain becomes alerted that something's wrong. So the person, as they walk in the waiting room, the part around the amygdala and the right caudate nucleus starts sending out a signal that there's something wrong, there's something wrong. Now, typically what happens is another part of our brain sends a message back, clarifying. For someone without OCD, when they come in the office, if they get a message that, hey, that doorknob, maybe it was contaminated, their brain will probably send back, and this is the left frontal cortex, by the way, it'll send back a message to the amygdala saying, no, the chance of getting the bubonic plague from that doorknob is probably 1 in a billion or 1 in a trillion. We really don't have to worry about this. And most of the time, even for people with OCD, that works well. For instance, the next time any of us get into a car, there's always the possibility we're going to be killed or maimed. And I don't know what the exact statistic is at this point, but let's say it's 1 in 500,000. And indeed, very few people with OCD won't get into cars because the left frontal cortex sends a message back saying, no, you're going to wear your safety belt and drive carefully and not to worry. But what happens with OCD is that message doesn't get back. The left frontal cortex sends it, but it doesn't reach the amygdala. So the amygdala ramps it up a little bit. You didn't hear me. You're in danger. The brain then begins spiraling, trying to send this message back. It doesn't reach. We don't exactly know why it doesn't reach, but the brain ramps it up. And the next thing you know, you could have spent 4 hours, 6 hours, or days arguing with yourself in your own head about whether my hands are contaminated, or should I wash them, should I not wash them. The treatment is counterintuitive because the very things that without OCD would make it better, with OCD make it worse. So without OCD, washing your hands will make it better. With OCD, it makes it worse. And we have to take the other route because, and the other route being not washing, and I'm going to explain how that works in a minute. And that's where we can make real progress. But let me clarify something too, because oftentimes when I explain to folks that, well, OCD is a neurological disorder, the brain's not communicating effectively with itself, then people will automatically assume, well, if there's something wrong with my brain, then I must need surgery or medicine. How else do you fix the brain? Well, the good news is that there is another way, and in fact, it's probably the most effective, and that's cognitive behavioral therapy, specifically using exposure and response prevention. And we have research now done by a fellow by the name of Jared Schwartz out in Los Angeles, who wrote the book Brain Lock, where he took a group of individuals, all with OCD. With their permission, they touched something that got their OCD going. So for somebody who maybe had a fear of germs, they would touch the dirt or doorknobs or whatever. So now their OCD is flaring up in their minds. And he said, before you do anything else, would you mind getting in that PET scanner? And we're going to take a picture of your brain. Well, they got in the PET scanner and they got pictures of the brain. And even though I'm not trained at all to look at CAT scan or PET scan photos and know what I'm looking at, I can see the difference. And the brain looks like it's on fire, or at least parts of it look like it's on fire. Well, for the next 3 weeks, all he did, no medications at all, was exposure and response prevention, a specific type that I'll talk about in a minute. And then at the end of several weeks, he had them go back, touch the dirt or whatever it was that triggered the OCD, and went back and took a picture of their brain again, and the brain was healing. The brain has the capacity to heal itself. It will form new neural pathways, and it'll find ways to work around when it's not connecting if it is given the chance. Exposure and response prevention gives it that chance. So what we do with exposure and response prevention, again, if I can use a germ or fear of germs, is I will ask someone to deliberately here in the office, actually begin by making up a list. Well, if you were to touch the doorknob if there were a thermometer from 0 to 10, how anxious would that make you? Well, maybe it's a 2 or maybe it's an 8. And we come up with a list of all sorts of things for them to touch in my office and outside the office. And then I want to be able to be with them when they do that, to help them, to coach them, and give them support. And we always start with the bottom of the list, something that's not too hard. I say, we don't want to go higher than a 4 or a 5. If they say, well, the doorknob would be tough, but I think I could probably do it. That's okay. So let's try it. And they'll touch the doorknob. And then, and there's controversy about this in the field, but we'll use one of several interventions. And the controversy is whether an individual has to pay attention to the anxiety or whether they can distract themselves. Now, the work Jared Schwartz did in Los Angeles, he primarily, not totally, but primarily used distraction, and he was getting the change. So the very first thing I teach people to do is how to distract themselves when they're getting an OCD spike. So they might touch the doorknob, and then we'll sit here and talk about their favorite restaurant for 5 or 10 minutes, and then see what happens with their OCD anxiety. And it usually takes about 15 to 20 minutes, and there's oftentimes a drop, or most of the time, let's say 80 to 90% of the time, there's a drop. Well, that's perfect. And then they'll go and touch it again, and we'll do the same thing. We'll do it over and over, and after a while, they'll get to a point where they'll say, no, touching the doorknob still gives me a little queasy feeling, maybe a 1 or 2 on that scale, but it's no longer a 5. Oh, well, that's perfect. Let's try another item now. So that's the first step. I'd like to say that distraction always worked, but it doesn't. So I want people to have a toolkit, so to speak. And if distraction doesn't work, I teach them how to work with the OCD so that they don't argue with it, because it's by arguing with it that it catches us. It's like quicksand. As soon as we start arguing with it, it has won the battle. And the best way not to argue with it is what I call mocking it. So when the OCD says, you're going to die because you touched that doorknob, I teach them to say, and there's some specific ways to do it, but the gist of it is they answer back to the OCD, "You're right, I'm going to die." Of course, the OCD will say, "You didn't hear me, you're going to die. You'll probably take out half the population in Charlotte while you're at it, contaminating them too." And then we're to say back something like, "Yeah, you're right. In fact, probably the whole population of Charlotte I'll take out." Because most of the time, the things the OCD are saying to us really are ridiculous. And there are some very structured ways to do that with our thinking, taking advantage of a process in the brain called habituation, which means if we hear something over and over again enough, the brain will get tired of it. We have them sometimes make up a story with these horrible things happening, or sometimes just using a sentence about these horrible things that the OCD is telling them. This is going to happen unless you go wash your hands, or unless you knock on wood 4 times, or whatever. These horrible things are going to happen. I help them not do that, and then use these statements so they don't knock on the wood or they don't go wash their hands, and teach them how to use the statements. Again, in about 15 to 20 minutes, there almost invariably is a drop.
In talking about the distractions, in a way it's good for some people. In a way, though, it kind of feeds OCD. Is that what the difference is?
There are some clinicians who say that if you're distracting yourself from it, you're not really confronting it head on.
Oh, okay.
And they believe you really should confront it head on at all times. I found distraction sometimes works and sometimes doesn't work. And it's always the first intervention I teach people, because I say, look, if you're at work and you get an OCD spike, but you can sit down with your Excel sheet in front of you and pay attention to that instead of, acting on the OCD, that's fine with me. And I've seen enough folks know that distraction can work at times, but it's almost never enough all by itself.
No, okay.
So again, we need several ways to handle a spike when it comes.
When someone figures out that they have OCD, whether it be just by going on the internet and figuring it out in some way, or they get a diagnosis of it, what's usually the first thing that you recommend they do?
The first thing I recommend, and it depends on their preference, and that is even before they meet with me when we have an initial session, is to gather as much information as they can and just read about it. There are a lot of good books out. There are a lot of self-help books out now. I have some clients that I see who actually prefer to buy a workbook, and we'll do the workbook together. My ultimate goal meeting with someone, because I tell folks, if you ever meet with someone and they say, look, I can cure this for you, turn around and run away as fast as you can.
I agree.
I wish I could say there was a cure. We don't have a cure, but we can learn to keep it contained. And that's the goal, to minimize it as much as possible and keep it contained. So my goal working with folks is to provide the skills and the capabilities to use those skills to keep your OCD contained so that you don't need me anymore.
Yeah, and I agree with that. To me, it becomes something that's you manage versus curing. I mean, I even see in my own daughter that there's still signs of it, that it doesn't really ever leave her alone. It still wants to try every once in a while to pop itself back out. But how do you inspire people to have some hope? Because like you say, they come to you and they're confused and probably frantic somewhat. And so what kind of things really help them find hope?
Well, for different people, it's different things. Some people, I'll talk about the research literature, which shows that exposure and response prevention is more effective. In fairness, maybe I should say every bit as effective, but every bit, perhaps more, than the best medications on the market. And for many people, it's a combination of some medication and the exposure and response prevention that gives them the best results. So the research literature shows that we will be able to help about 75 to 80% of the people, significantly help them. This is something that we can truly treat. The research is good. That's number one. Number two, we're going to go slow. Some people get panicked thinking, oh, am I going to have to do these horrible things that are going to scare the daylights out of me? And indeed, going to have to do things that are uncomfortable. Okay, the only way to conquer OCD is to face the fear directly. But that doesn't mean we have to make the experience so miserable that you'd have to, be out of your mind to do it. Instead, it needs to be done slowly and gradually, confronting things and tolerating the discomfort as you're capable of doing, and that you as the client will always be in charge of that. Because you know how you're feeling as a client. I don't know how difficult a particular step may be, so that you need to be in charge of that. But if you're willing to face some discomfort in a gradual, modulated fashion and, build up from there, where you're in charge of that process, there's a real good chance you're going to make progress and it's going to get better.
Well, that's great. Is there any final thoughts as far as recommendations or things you'd like to let my audience know, the OCD sufferers out there know?
Well, I might like to add that the research now is looking at the application of mindfulness in OCD treatment. In fact, there's a book that came out just, I think, in the last 6 months on OCD and mindfulness. Shala Nicely, who put out the YouTube video, is Fred in the refrigerator. And in fact, if people listening to this podcast have not seen the video, is Fred in the refrigerator, it is well worth watching. She was a business executive who suffered from OCD as a child into her adulthood. Finally found treatment, retrained to become a therapist. She and I had the pleasure of meeting each other down in Atlanta several years ago at the OCD conference when it was down there. So she's written a book on OCD and mindfulness. So sometimes we'll try to integrate meditation into this, and that seems to help also. And indeed, one of the interventions sometimes that I will treat folks is that, okay, you touch the doorknob, it creates a spike. Let's practice mindfulness now as a way to deal with the physical symptoms in your body. Let's indeed focus on them, but doing so mindfully as a way of handling it. And for many people, that's very effective and a bit of an eye-opener. I would put that out there, that's not going to hurt. The other point maybe I'd like to make is that OCD is incredibly creative. Just incredibly creative. There is no lack, well, let me back up. The more creative you are too, the more creative the OCD will be. And there's nothing it won't kidnap and take advantage of and catch you with. So it can be anything from a question of what's my purpose in the universe? And all of a sudden, a philosophical question that, everybody should be struggling with periodically gets caught in an OCD loop. And it can't be answered. Or, geez, I wonder what my wife's life was like before she met me when she was dating all those other people.
Oh my, yeah.
Or what my husband was like, and then they can't let go of it. So OCD can capture anything. The top ones we read about all the time, of course, are a fear of germs, a fear of hurting someone else, our children or people that we love, is number 2 or 3.
Yeah.
It's very common, but there's absolutely nothing that it can't commandeer and begin to control.
The last part of this then, Dr. Parisi, if you'd like to let the audience know how they can find out more about you, contact you, and if you want to put in where you're at, all of that, I'll give you a chance right now to be able to put that out there. Plus, let the audience know that I will have this information on both the invisiblewheelchair.com site and the familyocd.com site.
You can learn more about me by going to my website, and that's at www.drjoeparisi.com. That has my information about me, about my history, and some about the therapy that I do. If people are, after they read that, they're still interested in talking, they can contact me however it makes the most sense and is best for them, either through email or by calling me. I'm always happy to respond to questions.
Well, Dr. Parisi, this was very educational even for myself, and I so much appreciate you taking the time today to be able to talk.
You're welcome, Don, and thank you for having me.
That concludes this interview podcast. Please leave me a comment or question below. That gives me good direction where to go on future podcasts and interviews. I would love to hear your invisible wheelchair stories if you are willing to share it. If you would go to invisiblewheelchair.com and click on Tell Your Story. I want to remind you that OCD, Obsessive Compulsive Disorder, is treatable. I can help you get past OCD. So, if you have heard this interview podcast and other podcasts, and you feel like you need further assistance and would like to spend some time with me working through any issues you have, then feel free to book a session at focusedhealthyfamily.com or familyocd.com, or call me at 704-562-1630. I also offer $85 off of your initial discovery session if you mention that you heard it on this podcast. I hope you enjoyed this interview podcast and will join me for the next one. Remember, keep tapping, talking, and transcending your life to new heights. Thank you, and have a great day.